My name is Pam Bolton. I am a VP in Content and Advisory Services within our membership team at GBCHealth. And I want to turn our collective attention now to our workplace wellness panel. Even as business participation in global health has grown and evolved, the workplace and workforce are still very core to so much of what we do. And that makes sense. I mean, if we think in terms of sheer numbers alone, our members, employees, and the employees' families are probably about 50 million people. And those programs, as we know, are also effective and cost-effective. So in this session, we'll hear from the experience of some companies who have figured out how to devise very effective programs, and what I think is maybe even more challenging, figured out how to take those programs and adapt them to the many different settings, geographies, and cultures that where multinational corporations operate today. So before we jump into that, I would like to turn over the podium briefly to Naomi Roberts of Sentinel Consulting UK. Sentinel is one of our sponsors. They are also a very new GBCHealth member, and they are an important partner with us in developing knowledge around workplace wellness. Naomi.
Good morning, ladies and gentlemen. As a consultancy specializing in supporting companies operating in low-income countries and remote environments, a few years ago we were asked by a client to research the best way to apply their new and still developing corporate wellness program to their operations in sub-Saharan Africa. This project introduced me to the opportunities that wellness programs can offer, both within the workforce and, importantly, extending into the wider communities. We all know that there's currently not a universal definition of what a workplace wellness program is, but we can use this to our advantage if it enables us to find solutions tailored to local, cultural, and social preferences, increasing participation and ultimately increasing effectiveness. By getting out there and creating programs, we can generate a body of work that becomes the accepted norms, and we can come back to defining workplace wellness with those experiences under our belts. The challenge right now for program managers is making the right choices for your settings and for your goals, not just health goals, but business goals too. I'm honored to be sharing a stage today with some people who have made the right choices and who are currently running highly successful programs in their businesses. Our expert panelists will be able to give us a great insight today into their examples of leading practice. We're very excited to be extending this opportunity through a research collaboration between Sentinel Consulting and GBCHealth, starting very soon. The project will take a snapshot across industry of what wellness programs are in place in low and middle income countries. We'll use that snapshot to characterize and share leading practice industry-wide. Your input is really important to this study. It is, after all, what a coalition is all about, looking at what our fellow members are doing and learning from each other. I'm looking forward to launching that study in the next couple of weeks and meeting many of you in the process. Thank you very much.
So now I want to kick off our panel by introducing our moderator, Dr. Alex Govender. Alex runs the award-winning Workforce Wellness Program for Volkswagen Group, South Africa. And that program goes from condom distribution to chronic disease management, from emergency medicine to annual pap smears. Marries prevention, treatment, psychosocial support in a very holistic way for VW employees. And in fact, in recognition of Alex's expertise, he's recently been appointed as the HIV and TB expert for the global Volkswagen Group as well. We in GBCHealth have seen VW follow a trajectory similar to our own, from an earlier focus intensively on HIV and TB, where they learned a great deal, to more recent extension and enlargement of programs into workplace wellness much more broadly. very proactively. And Alex's experience in particular was very valuable to us, as he was a member of our Next Generation Strategies group that helped us as we worked through the process of expanding our mandate in 2011. So I'm going to now put you into Alex's capable hands for the panel. Thank you.
Thank you very much, Pam. Good morning, ladies and gentlemen. It's a great pleasure to be here for my first visit in New York, and I hope you guys are having as good a time as I've been in the last 2 days, and I'm looking forward to the sessions, this particular session, and going forward for the next 2 days, and I hope all of you are as enthused as I am for this particular session and for the sessions going forward. Now, just to get the context of the theme for today, I'd like to share with you a few interesting facts which will illustrate the problems that we have in workplace wellness, the challenges we have, and also the potentials to address it and to make that difference. Firstly, a few stats on unhealthy behaviors and impact on business, particularly in the low and middle income countries. 70% of all premature deaths, 14 million people, are linked to unhealthy behaviors. 80% are in low and middle income countries. Chronic disease is not just a public health issue, but also an economic one, and is underpinned by the 4 major health risk factors: cardiovascular disease, stroke, cancers, and diabetes. And they cost the US $2 trillion a year in lost productivity, as per the World Economic Forum. Smokers miss twice as many work days as non-smokers due to illness. 1/7 of the world's population, that is 1 billion people, is overweight. Right here in the United States, over the last decade, there's been a 33% increase in obesity and an equal 33% increase in the incidence of diabetes. Duke University, a study found that each employee with a body mass index above 40 cost employees $15,000 more. Employees have access to more than 54% of adult population globally. We have a captive audience in our workplaces where they spend most of their adult lives. Thus, the workplace is the single most consistent communication channel through which to affect employee behavior. A 2011 study of multinational companies conducted by Towers Watson showed that 75% of companies expect employee health to be the greater priority in the next 2 years. But only 32% currently have a global health strategy in place. And only 13% have actually communicated this health strategy to the entire global workforce. I had an interesting translation myself as I made my way from Uitenhage in South Africa to the Big Apple. I was tasked, mandated by one of my nursing sisters, "Doc, you are going to New York. You must visit the Guess shop and get me a Guess handbag." She was into this Guess stuff. So I was busy traipsing along yesterday down the Avenue of the Americas, and then we saw a few streets being blocked off. And after a lot of queries, I nearly landed myself a job as a prop in a movie. And we discovered that it was Ben Stiller, busy shooting a movie. The movie is called The Secret Life of Walter Mitty, and it'll be shown in 2013. And watch that space for yours truly. But that was an interesting transformation for me. Here was this fantasy that I was experiencing, coming from a developing country into a developed world. And as we take this theme forward, I'd actually like to reflect on that too. How can the local experiences influence the global policies in healthcare delivery? There's been much discussion on comprehensive wealth, but no global definitions or official standards. So there's much variation in health promotion programs. One often hears about a culture of health, but what does this mean? How do you build this, given the different cultures? And in taking that forward, there are two parts to this panel. First, a discussion among the panelists who represent 3 award-winning health programs to share strategies, best practices, and lessons learned from their efforts in setting global strategy and rolling it out locally. Second half of the session will be an opportunity for each panelist to share the story of implementing a specific wellness intervention in a specific country and how the company went about understanding and adapting to the unique cultural environment. And in discussing this, we also have the further privilege of having 4 of us in this panel from 4 different continents with different experiences across the world and a reflection of how diverse we are in the pursuit of a single desire of a good health outcome. Firstly, I would like to introduce Kathy Baase. She's a Global Director of Health Services of Dow Chemical Company. As a Chief Health Officer with the direct responsibility for leadership and management of all occupational health, epidemiology, and health promotion programs around the world. Dr. Baase is a key driver of the Dow Health Strategy. In addition, Dr. Baase is active in a number of organizations and associations. She is chair of the board of directors of the Michigan Health Information Alliance, a multi-stakeholder collaboration dedicated to improving the health of people in 14 countries of central Michigan. And Dr. Baase has been a board member of the Partnership of Prevention for more than 10 years and serves on the board of the Patient-Centered Primary Care Collaborative. She's a fellow in the American College of Occupational and Environmental Medicine and a fellow in the American Academy of Family Physicians. Then we have Rob Donnelly. He is VP Health, Royal Dutch Shell. Rob currently serves as Vice President of Health, reporting to the Chief HR and Corporate Officer at Royal Dutch Shell. He directs policy, strategy, and delivery of health services to Shell operations worldwide and leads a team of 610 health professionals in 70 countries. He joined Shell in 2001, having previously worked in the steel industry and served for 6 years in the Royal Army Medical Corps. Rob graduated from the Edinburgh University Medical School, and his professional interests include health and human performance. Then we have Dr. Rajgopal Thirumalai, who is the VP of Global Medical and Occupational Health for Unilever. He is also a member of Unilever's Global Health and Safety at Work Leadership. Dr. Rajgopal holds postgraduate qualifications in occupational health, public health, and preventive medicine, as well as health and hospital administration. He holds an honorary fellowship in occupational medicine from the Royal College of Physicians in London. He has also been trained at the Harvard School of Public Health in advanced leadership strategies for healthcare executives, the analysis, scientific assessment, and management of risks, and healthcare management for physician executives. In 2007, he was elected chairman of Medichem, an association of doctors in the chemical industry worldwide, a position he currently holds. In 2010, he was included on the editorial board of the International Journal of Occupational Medicine and Environmental Health. I will now go into the first part of our panel discussion. Kathy, let's start with you. Dow's Global Wellness Program grew out of a very strong health platform for US employees. Start by giving us a 1-minute description of the key elements of your wellness program. Then walk us through your process, both strategically and structurally, for building a global culture of health at Dow's US-based headquarters. Kathy.
Okay, thank you, Alex. As far as what our program includes today, it has different dimensions, and I'd say the first is that we have policies such as a tobacco policy and things that set the stage for one component of that. We have other things that aren't policies, but they're specific focus. Like we have a food philosophy, which talks about the intent of how our food services will be managed for health. And so those corporate level strategies, commitments, and policies are important. Second, our program is housed, our health group is housed in the Environment, Health, and Safety organization. So we have the cornerstone of our program is tied to our health assessment program, which is a screening that is offered to every single employee every year. And following that screening, they have a consultation with a health professional, which helps them map a personal program for health improvement and refers them to various resources and follow-up appointments so they continue to have engagement at an individual level for health. Those pieces are included along with this additional array. There are website sources, both an internet and an intranet. The internet is so that family members and retirees and people who don't have access to the intranet can have access to the web-based programming. And that covers a great variety of information, tools, resources, and links to on-site individual-based programs that people can use. It's available in multiple languages, so when people go to that site, they just select the language that they'd like to read that in. And then there are campaigns that are run periodically throughout the year on different topics, such as around World No Tobacco Day, we'll run a major campaign around tobacco cessation. And we'll have fitness-based campaign programs that last for 8 or 12 weeks with an emphasis that continues then for the remainder of a year. We also run a variety of individual small group programs which are held in person, or there's telephone or web-based education courses that people can participate in. Then there's other things which are focused in the individual community where the site might be located. So there's this macro sort of framework that's out there on a global basis which has these components, and there's a set of measurements and metrics which are global, and those things are standard, but then the subtleties and the implementation of that is molded by the people in the local geographies, and that's how it gets done. So we basically have a centrally managed organization, and there are regional directors around the world who have responsibility for certain geographic territory, and their obligation is to implement the full portfolio of corporate responsibilities for that kind of programming and to measure the success according to the metrics plan. But they have considerable freedom as well as the basic package that they follow.
Good. Thank you, Kathy. Rob, building on Kathy's story of Dow's global approach, Shell's strategy emphasizes country-level decision-making. Briefly describe Shell's wellness program, then share Shell's process of implementing and empowering health strategy locally. How did you decide what was centrally governed and what was locally owned?
Sure, so thank you, Alex. So Shell's wellness program in its current form is now coming towards its fourth, going on fifth birthday. And when we put it together, I think it's fair to say it was born of some internal dissatisfaction with what we had done to this point, that actually it wasn't really working for us. And I think the historical perspective is maybe worth just sharing very briefly. And that was because I think we had spent too much time focusing, if you will, on a medical and outcome-based model, and really paid insufficient attention to an employee engagement and behavior model. So that was really the key driver in putting the model together, that this was really all about employees. It was putting them at the center of what we tried to do and building a package around them that would help them be the best that they could be in terms of their health and their performance and their engagement in the workplace. And I've been blessed with a boss who's really kind of gets that model. And actually, I'm sure at some point this morning we'll get into conversations about KPIs and metrics and so on, and we have lots of that stuff, of course. But one of the starting points for our program has been a belief that actually healthy people perform better, and it's in the company's interest and it's in the employee and the individual interest to maximize health, whatever that is. So we really tried to put a program together based on that model. And I think as we started to try and build principles, we said there are 2 or 3 things that we really want this program to be. We want it to be a very engaging, relevant experience. We want it to be synergistic and not competitive with things that we are already doing. So to Kathy's point about tying it in with occupational programs, other things that are going on, that was a key part of our design as well. And finally, we wanted it to be synergistic with our HR benefit programs, because like many of those in the audience, we run multinational benefit plans. They're very expensive. The inflation in those is well recorded elsewhere. We wanted to try and find levers across these 3 different principles that would talk to each other. So we put together a global program with some basic parameters and design that said it's focused on behavior and behavior modification, and not fundamentally disease management. And that for us was actually quite a key distinction. It's not to say the latter is not important, but it's how we decided to focus our strategy and our program. We said we would focus on exercise, nutrition, and smoking. Because again, if you then extrapolate from those to cancers, cardiovascular disease, all the things that you mentioned, Alex, the public health challenges that we face in the world, you can really map some pretty close links between those 3 behaviors and those endpoints and those outcomes. And then we said we'll build a program around these in the different countries where we operate. And in a sense, the analogy I often use is we're kind of drawing the lines on the pitch. So we say, I have to be careful with the language I use because pitch may not mean the same thing in different people speaking a different language in English. So if you think of a soccer pitch or a football pitch, we were kind of drawing the rules and saying that's the space in which you can play. But then we said to countries, well, you go play in your way, something that's immediately relevant for you within these basic parameters and these rules. And that's something we thought was terribly important. So Shell operates across about 120 countries. We have something of the order of 90,000 employees. And it was very obvious, working with the team that put this together, that what might be an entirely appropriate, indeed a world-class program in the United States, couldn't just be translated to South Africa or to the Philippines or to Australia and have immediate relevance. And if I go back to one of the principles of the program, it had to be locally relevant and engaging. So with those basic parameters, we then turned it over to the local teams to say, well, against that framework, what can you implement? Again, tying back to your benefit design, your local structure, your local engagements. And that's where I think we've had our greatest learning, some of our greatest successes and some of our disappointments about just how successful we've been able to do with that. But the basic model has been to take the basic design, then engage locally through existing leadership teams. We've created in most countries what we call the Be Well steering team, and that's even replicated at smaller asset levels. So for example, in some countries we might have a country level team. In others, we've actually replicated that down to the refinery level or the offshore asset level, because you then give local people the local ownership of what it is we're trying to do, and you say to them, well, what would a program look like for you in this space? And we've asked them to help us design it. And some of that's been enormously successful, and perhaps we'll come on to some examples later on. But that's how we've tried to create local ownership of what is essentially a global program and a global priority. It does come with tensions. Of course, there are always people out there who want to spread their wings further than you would like them to spread them. And that's one of the challenges we can perhaps come back to.
Great, Rob. I'll get into some of the detail a little later. And Raj, Unilever took the distinctive approach of applying a regional lens to the company's global strategy by basing its global health leader in a local market. This was also the first time a multinational corporation located a major functional role in India. Based on your unique perspective of both sides, and given both Kathy's and Rob's overviews, what should global and local actors know about each other to enhance the translation process? Start by briefly describing Unilever's wellness program.
Okay, good morning, ladies and gentlemen. Unilever is a company which operates in around 100 countries and has more than 175,000 employees. So our challenge was to have a program which would find resonance in each of the country in which we operate. It wasn't simple, but what we did was when we revamped our medical and occupational strategy covering 2011 to 2015, we took a lot of internal stakeholder reviews, which included people from other parts of the world other than the major ones in Europe or in America. It had the effect of getting a buy-in at the very early stage itself of formulating a strategy. And having said that, our main global strategy is based on the twin pillars of health promotion and health protection. Health promotion is to help all our employees take charge of their health, and health protection is to prevent work-related illnesses from creeping in at the workplace. And under these, we had some standard programs like the Lamplighter program, which looks at health and well-being for all our employees across different parts of the world. And how did we ensure that it did not get lost locally? The Lamplighter is a global program, for instance, which looks at covering physical exercise, nutrition, mental resilience, as well as health risk assessment, and gives a score to each employee to tell them what their health risk is. These are the broad parameters, but individual countries are actually free to choose what sort of interventions they want to do in the space of either nutrition or mental well-being or indeed in other aspects. What we also did was to have a series of standards which were the bare minimum mandatory, which was then rolled out across all the countries. So you could go a step further, but you definitely had to have a bare minimum mandating medical standards. So that's the way in which we tried to approach it. A, get more of a buy-in by involving people in decision making, whether it's local, regional, or at a global level, and then give them the flexibility and the freedom to operate at a certain basic level, but then scale up from there.
Thank you, Raj.
Alex, could I just
Yes.
comment on something Rob
Yes.
said? I really was struck by something that we've learned as one of the major lessons in our 20-some years of trying to do this as well, that it's not so much about the tactical program elements as it is the principles that underlie the program. And one of the wonderful things about corporations is that it's one of the places where there's the tightest overlap, where the best interest of the individual employees is also the best interest of the company. And that if the people are healthier, that's how their quality of life is improved and their value. But it's also the mechanism by which the company benefits is by the improvement of health. And if you can secure the engagement of the employees by having principles where everything that's done in the program is done as a health advocacy model, that it really truly is done in the best interest of the health of people, and there's integrity which is through every aspect of the program and its design and its implementation to that, then the employees perceive that, and therefore they engage more readily in the program if it's genuine and has high integrity. And it's so important because participation levels are essential to success. So I think focusing on those principles of what really you're going to commit to in any stage of that design effort and strategy building is so critical. So I just thought I'd make sure to raise that point. It's something you brought up which has been central to our efforts and our success.
Interesting, Kathy. Raj?
I think it's,
Yeah.
I really do think that's key to what we should be trying to achieve in this space. So many of you will be familiar with, health risk appraisal assessment programs and tools, and there are different ways of incenting people to participate in those. And you will find many companies who achieve apparently extraordinary rates of participation based on, cash incentives for discounts from health insurance plans and so on. And I don't criticize that. It's not particularly a model we have used, and certainly not extensively outside of the United States. The main reason being, it comes back to this point that Kathy's just raised about really what is engaging for the employees, and are you engaging people for a genuine reason? Do they really believe it? When I had a kind of central experience early in my time in this job, when I was talking to a staff council, which is the equivalent of a union, and one of the union reps said, your website just doesn't do anything for me. It's all management speak, and it tells you about how you're going to drive productivity of the company through healthier employees. And he said, that might be good for those guys upstairs in the C-suite, but I really don't care. I would actually like you to write something about me and my health. And it was a real wake-up call for me. I took an awful lot from that, and I've actually tried to reposition the program, what we do, and how we talk about it ever since in a much more people-centric way, and I think that's actually really important.
Rob, thanks for that input. And my own experience when we started off with our HIV and TB programs way back, one of the first things we did was to sit around the table with the board of management and the union. And together we mapped the way forward. And there was one way to increase the participation, to get active involvement and then give feedback meetings. The other thing we did was, after a few years, we noticed that the testing rate for HIV was very, very stagnant. It was stuck at around about 63%, and we just could not get it up. And when we analyzed the statistics, we realized clearly that it was the people sitting in offices and people in the higher staff bands that were not testing. So that is when we offered free screening for other chronic diseases like hypertension, diabetes, and cholesterol. And within 6 months, we had our participation rate for HIV testing up to 87%. We are actually on the third round of doing that, and we have also used incentives. My director took issue with me for offering people T-shirts and caps. But I said, I don't care, as long as the guy knows his status. That's what's important. And we managed to get those participation rates and also sustain it well into the future. Share with us the actual steps you took at the ground, including any innovative approaches you took, and what this demonstrates about both the challenges and the opportunities of addressing health issues through a localized lens. Raj, at Unilever Tea in Kenya and Tanzania, you piloted a program to address women's health and well-being through a male workforce education and awareness-raising program. What were the considerations from both health and cultural perspectives that the company took into account in designing and implementing this program?
This was a very unique experiment in terms of devising a program with the support of US Aid, and it was called as Healthy Images of Manhood, where we actually realized that in spite of our best efforts, we were not able to make much headway in the control of HIV AIDS in our plantations in Unilever, Tanzania. It's a big place with around 10,000 employees, with 30,000 family members, and 200,000 people from the community taking advantage of the support services which we were providing there. So in spite of having peer health educators and doing all the right things, we were just not able to get up the rate of voluntary counseling and testing, as you were just alluding to. And indeed, we found a dichotomy in terms of behavior, etc. So this was a program where the peer health educators were actually trained in addressing the gender inequity by asking men to participate in a series of behavioral modification changes. What it did was to integrate the family planning services, the reproductive and child health programs with the HIV program. And over a period of around 1 to 2 years, we were actually able to engage around 12,000 couples in terms of talking to them, telling them about what is safe sex, what is planned parenthood, what is spacing between pregnancy, what needs to be done to prevent mother-to-child transmission, what are the precautions to be taken, and all the other usual stuff, albeit this time by actually focusing on the men folk out there. So the macho image gave way to a caring, a concern, and at the end of the program, we were actually surprised to find that men who would otherwise not carry their children to the school actually started doing that. There's a big change in the way in which the behavior of men undertook a change. They became partners in terms of helping us. And at the end of the program, what actually happened was the VCT rates actually went up significantly, 60% more. People who came in for family planning consultations also went up by around 25% more. And all this was done through a spirit of partnership. We would hold plays, we would hold dramas, a lot of other activities which actually emphasized on the men their responsibility in terms of shaping family health. So we tried to attack family health in a positive manner through the inputs of the men folk themselves. And it did make a big difference in terms of the rates which I just mentioned. Apart from that, other companies like Unilever Tea Kenya, Burundi, and various other places also started adopting this. So that's the positive impact in terms of engaging men to address gender inequity as well as to let's say, marshal resources to bring all platforms into one holistic program, be it reproductive and child health or be it HIV/AIDS intervention.
This is something we should be doing more often, engaging the male workforce to address the gender issues and improve participation rates. So it's a very interesting way of actually doing it and very, very relevant and important. Thanks, Raj. What lessons should be applied in expanding the rollout of this type of program to other geographies?
Okay. We can learn, we can actually learn from the experience here, and this is an entirely replicable program. I don't think that there's rocket science involved in this. It is just that you need a group of dedicated peer health educators who actually know how to engage with men, and there are standard tools available, so you don't have to reinvent the wheel in terms of involving communities, in terms of, most of the times when we talk about behavioral changes or knowledge, attitude and practice changes, we believe that it's a one-way discourse where the peer health educator comes, talks to people and gets back. But behavioral change doesn't happen that way unless there is a two-way interaction. So programs like this, which have a two-way interaction and which actually put the onus of taking care of health back in the hands of the individuals concerned, can make a significant impact. So to me, you can actually learn from experience and translate it around.
Excellent. Thank you, Raj. Rob, regarding the health and wellness campaign in the Philippines, the particular profile of Shell's workforce in the Philippines demanded a number of local adjustments to your comprehensive wellness program. What was the local or cultural scenario that drove the need for adaptations?
Yeah, so I think we've had nearly 20 country rollouts now, and I've kind of looked at all of them with the team globally, and one of the ones that really caught my eye and my imagination was the Philippines rollout. So the Philippines is a big country for Shell. We have production assets there, both on the upstream, so that's oil and gas production, but also on the refining side and the retail side. But we also have a lot of our service centers, so our finance and HR service centers, and I suspect many of you will have this same model where you have so-called offshore facilities and resources. So we have a big service center there with some 2,500 employees. They tend to be, for our industry, relatively young. So the average age is in the 20s, early 20s. They tend to be quite high turnover. And they tend to be a population that has particular challenges with the style of work we ask them to do. So for example, they'll quite often work a night shift for them because it's in sync with daytime working in, say, the United States or Europe, where they're the clientele that they're servicing. So the program really had to speak to them. Now the other thing about the Philippine culture, if you've ever spent any time there, they love singing, they love dancing, they love being together. They're probably the most people-orientated collective I have ever known. So we actually, or they actually, I say we, I didn't do it, I only saw the outcome. But they absolutely tapped into what they like to do as a way of engaging people in the wellness program. So as a way of running, for example, health fairs and getting people to come and do their health profiles and get access to various health promotion vehicles, they had a dance competition. And it was modeled on a talent show. I can't remember whether it was Idol or X Factor or So You Think You Can Dance. But they had a dance competition that ran right across the country. And they had this huge participation, which included the country leadership team. So the top 8 leaders in the country entered their dance routine. They were all videoed. They used modern technology platforms. So these could all be, it had to be like a 1-minute clip or a 2-minute clip or something. It was on the IT platforms. That was all used to share, to get people engaged. And it just sent this ripple of energy through the company around wellness. So, the lesson I think there is engage, use what works best in a country for engagement. And if I had taken that same program to the United Kingdom, we Brits are kind of a bit reserved, to say the very least. We're kind of uncomfortable with a cuddle. Air kissing is out of the question, and dancing just isn't going to happen. So, tailor your program to the country and set yourself up for success. And I could tell similar stories of other countries in the world. So one of our other fantastic programs has been in Nigeria. And again, the success has been to tap into the local culture of how people like to work together, participate as teams, and then you hang your health messages, your health activity, your programs off things that work for people locally.
Rob, I can attest to the singing and dancing of the Philippine people. Yesterday, while traipsing around the wonderful city of New York, I came upon a protest march by the Philippine people. It was a protest about occupation somewhere in China, I think. And there was lots of singing and dancing there, so I can actually attest to what you said. Rob, what lessons learned should be applied in approaching localization in different contexts?
So, I mean, I mentioned briefly earlier on about incentives and so on. I think again, be very culturally sensitive to what people find engaging. So, for example, in the Netherlands, where I'm based at the headquarter office, people actually are quite offended by the idea of being positively incentivized to participate in the program. That's just how they feel about it. In other parts of the world, very simple incentives, so t-shirts, pedometers, whatever, active lunches and learned, whatever. They've been very powerful incentives. So I think be very sensitive to what people do find engaging locally. I think the other thing is to be sensitive to the health agenda locally. Across 120 different countries, we have lots of different challenges. There are some common ones, and unfortunately, we're finding weight gain and disproportionate weight gain is not by any means only a developed country problem for us. We're seeing it across the world in all of our assets and operations. But of course, in some countries, we have additional challenges and problems. And so that's where I think things like synergies with occupational programs, where you position messages in the context of the work that people are being asked to do, the heat threat, for example, of working in the Middle East, the ongoing HIV challenge in many parts of the world, but particularly in some parts of our world. I speak as our forecourts in South Africa are faced with a contracted workforce that still have a very high prevalence of HIV in the 20-odd% range. That's a massive personal and business challenge that doesn't exist in some other parts of our workforce. So I think you do have to be very sensitive to what is actually the really relevant issue for people in individual countries. And you kind of ignore that at your peril, because if it doesn't feel relevant to the people on the ground, they will not engage and participate. And a very simple example of that would even be in the Netherlands, for example, where we rolled out our program based on exercise, nutrition, and smoking. And it had a certain amount of success, but it's when we started to add some mental health and well-being and resilience to the pack that you saw more tick up and more pick up, because that's really what people were engaged in and interested in. So I think local relevance is really important.
Excellent. Thanks, Rob. And Kathy's been doing some work in Raj's country, in India, with tobacco cessation. Eliminating smoking from working environments is a growing priority for companies. GBCHealth is in fact helping to champion companies' efforts in this arena with its involvement in the global smoke-free worksite challenge that was launched this past September. As the world's second largest consumer of tobacco, and with 1/3 of adults using some form of tobacco, India is a challenging setting for going smoke-free. Yet Dow successfully introduced a no-smoking policy in all of its work sites in India in 2009. Kathy, what steps did the company take in implementing the program within the cultural context, including the custom of smokeless tobacco?
Thank you. The approach to tobacco cessation in India is really embedded within the whole effort of our cultural aspects of the program. So it wasn't in isolation. And so it was part of this overall focus on genuinely caring for and the well-being of people. But the uniquenesses of this program, I mentioned in my earlier comments that we focus on World No Tobacco Day in May, so it's coming up here. And we started doing this in a pretty significant way in 2007. And although every country was asked and every site was asked to focus on World No Tobacco Day, they could develop some of their own approach to that and how they were going to do it and what was going to make it work. So in India, what they did, in addition to what was pretty common, everybody would sign people up on a commit to quit process and have little quit packs and things like that. They really were very creative and extraordinarily successful in India. One of the things they did was to partner with local hospitals in a preventive oncology groups within the local hospital, and I'll just focus on one site for a moment. And they brought in specialists who would perform oral exams, and because of the emphasis within India on chewing tobacco and other forms of tobacco, not just smoking, they really focused on oral cancers and did the screenings, and they had the folks were coming in every 6 to 8 weeks for an entire year following this up. And all of the people that had signed up for the Commit to Quit in the first year, and they were tracked regularly with follow-up visits by our health staff and by the partners from the local community hospitals. They started with Tata Memorial Hospital and one Apollo Hospitals in another site, but they created these partnerships and the tobacco cessation, and this was built throughout with the HR benefits program paying for the nicotine replacement therapy and coverage and things like that, so they had many aspects to it. But the net result was that in that first year, about 40% of our tobacco users quit and maintained their quit status for a year. And in fact, 5 years post right now, we're at 50% quit rate from where we started in 2007. So it's been a very successful effort in those years, and we've translated and learned a lot of those program elements and shared those with other sites, and where it's made sense for them, they've adapted that to their local culture. But this emphasized, I guess a lesson learned out of this was about the power of culture, in that there was such a strong sentiment among the sites in India that they really wanted to become strong in the health culture like other sites within Dow, which was highly noted for such a powerful culture focusing on health. And they were relatively new sites in India for us compared to some of the other sites and the company being older. So they wanted so desperately to really stand out with success on this program. And after a while, we had an unintended consequence. Like our physician there once called me and said we had some other little issue showing up, and that we had people not coming into work for unexplained reasons, and we couldn't figure that out. So we began to call them and say, well, why didn't you come to work? And amazingly enough, there were people who were so ashamed about the fact that they had not maintained their commitment to quit status. They had relapsed, so to speak, that they didn't want to come back to work because they didn't want to have let their colleagues down. And I was shocked when I heard this story, but it illustrated to me this is how powerful culture is. And if you can be successful, and of course that's not really what we were trying to do, was get people to be that ashamed of their recidivism, but we really brought that to light and created buddy programs and more success, and it changed the approach a little bit more, but it really emphasized to me we're onto something with our success and our culture, that people really see the value of health and want to participate in that, and we've adapted because of it.
Thanks.
Alex, could I offer just an insight on that,
Sorry.
if I may, Alex? Because I think that's a fantastic observation that Kathy's just made around, never lose sight of the people amongst the statistic, yeah? Because I remember, again, going back a few years, that I attended a conference where the advice from some of our panelists, just as kind of we are today, was, reframe your expectation of success, because it isn't 100% of people changing the behavior you want to change. And that's quite difficult for somebody coming from an engineering company where actually, if I'm thinking about wells drilled, the only acceptable figure for wells drilled is 100% success and 100% safe. But not 100% of people are going to be able to stop smoking, and you have to get comfortable with that, and you have to get senior management comfortable with that. It's better that 40% give up and 60% are either not ready to give up, or they're still thinking about it, or they've tried and they've not succeeded, but they don't feel punished by that. They can still be included and try again another time. So I do think, again, this is back to this is actually all about people, and putting them at the heart of what we do, and not getting lost in the statistics.
Thanks. Raj?
Yeah, in Unilever, we just have rolled out a global no smoking sort of a standard which kicks in from 1st of June of this year. And believe me, it's easy for getting people in India to give up smoking than for some in Europe and some parts of America. And we are actually struggling with some of the program component in terms of how do we ensure that people do give up. And the strategy which we have approached is that there's got to be a buy-in. If there's no buy-in, which would sometimes involve extended union negotiations, etc., and it has got to be put on the plank of employee health and well-being. We are definitely interested in the individual who gives up smoking, but also we are equally interested in all the other people who would otherwise be indulging in passive smoking. So there's got to be a multi-pronged strategy to look at how do you address this. The pushback comes sometimes from supply chain people and HR colleagues who actually try and look at your definitions and say, okay, you said no smoking within the premises, but this does not constitute a premise. So we have gone the entire route of defining what is a premise, where can somebody smoke, where can somebody not smoke. So it's a big challenge for us to get 100 countries on board, but we are getting there. And I think the most important thing, as both Kathy and Rob said, is that you need a total buy-in and a commitment, which can only happen if you position it on the plank of overall health rather than just looking at isolated individuals. So it's not about punishing people who smoke, but it's about protecting people who don't smoke. So that's a real challenge.
Thank you, Raj. Ladies and gentlemen, I think we've actually already had some really interesting comments about participation at different levels. And just like we are challenged with the issues of health and wellness in the workplace, we are also challenged with time. So my Q&A session is going to be quite short. So I'm going to open the floor now for a few questions. So let's go for it. You're most welcome to ask any question to the panel. The back thing. There's someone with a mic there at the back.
My question is about how what motivated you first to make the shift from, and for example, a more specific health-related program, like maybe an HIV workplace program, toward a broader program. What has been the cost and what has been the benefit? What are the arguments that you're using and what is the evidence you have that it's been worth it?
Okay, to start off with a response, I alluded to earlier how we were not very successful in getting the testing levels of HIV amongst the workforce. But then when we included, like the panelists were saying earlier on in each of their presentations, including each of a specific health intervention into a larger offering, that works. And that's exactly what we did when we started all the screening, including that with wellness counseling, including that with our legally required medical surveillance programs, all at a single offering. That seems to work. And if you look at evidence that's been coming out recently about the benefits, it was clear that for every dollar spent on workplace wellness, you get at least a $3.5 return on investment in worker health and productivity. Any of the panelists like to answer?
I can just add here that within Unilever, we did a cost-effective analysis and benchmarked ourselves to peer groups, etc. This was a study done jointly in conjunction with the Lancaster University. And the first results which came in actually showed that our health promotion programs had a cost-benefit ratio of around 1:3, just like you say. For every dollar you invest, you get $3 back. But having said that, if we look at the entire range of programs, what we try and measure in terms of the benefits out of our program are what are the costs which are associated with traditional stuff like absenteeism, but more importantly, with what's happening with presenteeism. Presenteeism is a state where you're not fully fit, but you still come in and work. And that costs huge amount of money to any organization. And typically the costs of presenteeism are 3 times as much as in absenteeism. So that's a very important thing to know. In terms of the health protection programs, if you have a good ergonomic program on the work site, the amount of money which you save by preventing conditions like repetitive strain injuries or other musculoskeletal injuries, or even in terms of bringing down workman compensation, they all actually speak for itself. So a good health program is actually good business sense. That's what we feel within Unilever.
Thanks, Raj.
I had just an additional comment that In our case, the formal corporate health strategy was built upon a business case, and the economics, which you referenced in your introductory comments, Alex. But I expanded the rationale beyond just sort of the pure sort of healthcare costs and even presenteeism, and that there's a strong line of sight to other corporate priorities, which we've been careful to map. For example, the health of the workforce is very important to the achievement of safety objectives, and safety is very important in many companies. Additionally, sustainability and the focus within corporations on sustainability and how health factors into that being, one of the more important challenges facing the planet, and with non-communicable diseases, and how this is in fact aligned to the other corporate priorities in our corporate social responsibility efforts, the capacity to attract and retain the talent that you want, and how important the company's focus on health is as an important message and part of the capacity to retain workers in highly competitive markets. And so just as the health issues might vary from one site to another, the corporate priorities and the challenges with which the health programs align vary. We know in some of the most competitive markets in Asia how important our health programs are as part of the retention efforts. So I guess what I'm trying to illustrate is that look at the entire array of top corporate priorities and how those health programs are integrated and aligned. And as far as the cost, to be honest, ours has been what I would consider fairly limited because we've built it into and upon our overall corporate health programs in the EH&S world, and then have also built it into everything that's happening in the fabric of the organization rather than layering it on as sort of an additional cost.
Thanks, Kathy. Sorry to do this to you guys, but we just going to take one last question, and then we have to wrap up the session.
Could you address the... They're coming through.
Okay. Go for it.
I'm curious if you could address the pushback, of course, coming from people outside of this room, that is typically characterized as we're becoming nanny companies. In other words, we're taking care of our employees in areas of their health and well-being. That's their own personal business. And across cultures, I think that's manifested in different ways. Has that manifested in your companies? And if it has, how have you addressed that in a creative way?
So perhaps I could speak to that, because I think that's a really important observation, actually. And in fact, maybe in Shell it was the reverse. We felt we had become too much of a paternalistic organization, and we wanted to move some of the accountability back towards the employee. And actually, so one of our design principles in putting the program together was that at the end of the day, the accountability for personal health, lifestyle health rested with the employee, but the accountability for the company was to create an engaging, inspiring platform on which you actually had the maximum opportunity to make some good choices. But that's the headline, and then underneath that, we've had some very deliberate policy changes around benefit design, HR policies and practice, and they've become less towards entitlement and more towards making choices and individual preferences, but that the person making those choices is the employee. So a little bit like Kathy has just said, I'm a great believer in designing your program around the culture, direction, and corporate strategies that are going on. I mean, I think if the rest of your company is heading in a one direction in terms of saying that there is no choice and or there's lots of choice and it's very paternal, and you're trying to go exactly the opposite direction, that will not work, because whether you like it or not, health is not bigger than the company, and frankly, in my view, nor should it be. It should be part and parcel of the beast that's morphing its way around, and most of you will know if you've been in corporations long enough, the pendulum swings from time to time, and what was out of flavor 5 years ago is kind of moving back in favor this year. But I think if you keep really at the heartbeat of your companies and can follow the trend of the direction and the corporate policy building, I think that is actually a key to success here.
Thank you very much, Rob. And sorry for pushing this session a bit because it's running out of time. And I just want to conclude by, first of all, thanking the panelists for their various inputs. And clearly, I think it's been well illustrated of the potential we all have in the various ways in which to address workplace wellness and the successes that we can easily achieve. There are difficult trends that are emerging throughout the world, the developing and the developed world, in the actual workforce that is available, and the aging workforce, the incidence of chronic diseases, and I think we are uniquely positioned to be able to break that link between the aging population and the incidence of chronic disease. Thank you very much for your participation, and my apologies once again for the short Q&A session. Thank you. Thank you.